Hi, my name is Dr. Neil Pande. I'm from Kathmandu, Nepal. I'm going to talk about dentistry in the new normal. This is the talk I gave on the South Asia Summit on COVID recently. And some of my friends told me they were not able to get the whole thing because of some technical issues. So I'm going to repeat that again. First of all, as all of you, as most of the dentists, we were really woken up by this not being able to work safely. As you know, we have been dealing with aerosols since day one of our clinical posting. We knew about it. We knew about the airflow. We knew about the diseases that it can transmit, but it's some area which we were not given so much importance because there was no imminent transmissibility like what we're seeing today. Now, what happened suddenly in February 2020 is we suddenly got across this virus 500 to 600 times smaller than our human hair. 500 to 600 times smaller. And our challenge in dentistry was always because we work in close proximity, and WHO and CDCs were saying 6 feet distance for common man, which is not possible with us. We have to work in a proximity of less than 1 foot at times. Secondly, most of our procedures are aerosol producing. They produce aerosol because whenever we use our handpiece, the air, the water that mixes with the area and just floats around. And the mouth was a harboring ground for coronavirus and is a ground for coronavirus. We know that. Another thing was the mask. We were wearing surgical mask, but was surgical mask enough for this? Which is the size of the virus is 0.125 microns in average. No, it was not. Even N95 can only kind of filter 0.3 microns. So 0.125 virus was very difficult. But we were using surgical masks, which basically protected our patients from us rather than the other way around. We know now that that surgical mask just protects the other person, not the wearer, right? Next is fomites. One of the lucky thing we had here was because all those aerosols that dropped on the surfaces with virus and bacteria and whatever microbial load, we always used some kind of some kind of solution to wipe them down. And thankfully, coronavirus can be disinfected by the use of 70% alcohol. It gets denatured with that. We can use, hand washing because it's got a lipid cell wall, so we could easily disintegrate that by washing with detergent and stuff like that. So that was great. That was one of the good things, easier for us to manage. But the biggest problem here was the aerosol mask and the 6 feet distance that we needed to keep. So as normal, we as humans, we try to figure out solutions. We figure out the problem first. Now we have to figure out the solution. So we started looking around, and we even went into, figuring out what the mask is all about, how much, and we also found out that it's not just the mask's penetrability, but also the electrostatic fiber on the N95. That is very important, which was not found in many fake masks. We could not get the right mask. We were always still in a lookout actually. And the guidelines now is talking about FFP3 when we are working on FFP2. Now, FFP2 means N95, FFP3 means N99. So, but a good 95 also we're not getting right now. So we are still in a lookout. We are still working with risk attached. So first, one of the things we have to look for, still find out, is we have to get that FFP3 mask. We made some guidelines. Because there were no guidelines anywhere in the world, so we had to create something out of our head. We also did a lot of webinars across the world, got some experts from around the world, clinicians and things like that. We wore crazy kinds of PPE, tried different things, and then figured out, okay, what is necessary and what is not. So rather than at the end, best thing is to, whenever there's a problem, you figure out a problem, of course, discuss, you read, you study, but at the same time, you kind of try to get the expert's opinion also. So my concern mainly was, again, one was mask, of course. Another one is aerosol. So for aerosol, what I did was got some consultation with the HVAC engineers to basically try to get that whole aerosol out of my operatories. And that's when I installed these two systems there on the two units, which one has 15 air changes per hour and another one 23 air changes per hour. You may say, oh, you must have spent a lot of money doing that. Not really, actually. I mean, if you do it well and if you have the right thing, and I of course, in terms of right now's economics downturn, it's a lot of money, but for investment wise, to make it safer for our patients first of all, and then for ourselves, for our families, for our staff, is, this is a small price to pay, I would say. It costed me around $800 per unit, and we fixed two of them. Also fixed a barrier between the reception and the clinical area, so we were separate. So it was also a time is a time for us to basically upgrade dentistry. So reception, we can now fix it something like a something like a pre-operative area when you go into surgeries, and the inside you can call it a surgery kind of thing. We had 4 units, 4 dental chairs, but 2 of them we are not functional right now because we're doing a very one patient at a time kind of thing with a very small team. So that was another thing we did. And those unit 2 and unit 4, you can see we've used it for donning and doffing procedures. No materials or things like that are kept in the rooms. It is all passed out from the outside to keep it away from the aerosol, whatever is produced. And the thing we made is the aerosol is caught at the source itself. As soon as it is produced next to the mouth, we have a kind of a tubing that it goes out with a inline exhaust system like this one. So we got into work, got all this made in Nepal. The inline exhaust system is from Ukraine, a very good one. I'm quite happy with that. And then, all these are our own unique way of figuring out how to do it. And we did it. Actually, those, if you see the arm next to the behind the chair which is attached, so that is actually made locally by one of my staff in the clinic. So this has been like time of innovation. Hopefully it'll all work. Then of course, once all these are done, our thing was the processes. We have a strict processes around. Patient does not come to the clinic. There is no walk-in patients. They always contact. So once they contact, we send them a form. The form has a kind of a screening telling us what to do, like whatever they have, what is their level of pain, level of problem, everything is in the form. And then that form is screened, and accordingly, if the patient needs emergency treatment, we kind of schedule that. But if it's in a non-emergency, we try to just do teledentistry as of now, because we're in the red right now. Once we go a little bit on the yellow or the green, then maybe we can go into the other procedure. Now, once the emergency thing is there, patient comes and all that I'm going to show you in a video format. Okay, so ladies and gentlemen, let me show you what we do at our practice. So online screening form is this one, it's checked, and the teledentistry happens if the patient doesn't have to come. And then we go into a patient arrives. Once the patient arrives, gets his her hand sanitized. That's the first thing. We have already sent them earlier before what to expect. So rings the bell, and we actually send them this video before they come in, so they know exactly what to do. Then a mask, if they're not wearing well, or if they're not wearing, we give them a mask, and we just check their temperature as well, maintaining 6 feet again. And once they're cleared of that, we bring them in, give them the shoe cover, and the process moves on. You can see the mask is well worn. That's very important for us. No mask, nobody allowed without a mask, including this happens to staff also. Every staff, every doctor goes through this process once they enter the building. Then the gloves are also given so that they're not touching the fomites. And then after that, the screening is again re-screened. They need to sign in that. Pens are kept separately. Ambient temperature, ambient environment is created. Consultation happens in the reception itself because keeping that distance. And as you see, I've segregated the clinical area to the reception. So this is what I was talking about earlier. Of course, hand washing and all those dunning procedure is very, very important. So we use a protocol, a kind of a sequence where the N95 mask is always worn once you're inside the clinic. So on top of that, we wear other masks, the surgical mask, head caps, of course, and then the goggles. This sequence helps us to do it in a correct, easier way. Once you get used to this sequence, it's so much easier. Then, of course, all these bodysuit and the shield and the gloves. So single glove is worn here, and the other glove is worn inside the operatory. Patient is not allowed to take in anything inside. Once they go in, they go empty-handed. They just don't touch anything. They take off their mask and they gargle with the mouthwash for 1 minute. And our instruments are all sterilized, packed, pouched. All those things are there. Then no suction is used. No suction. So it's all, no spittoon is used. Not suction is used, of course. No spittoon is used. And there we go. A treatment, and short and sweet treatment. No talking when we are there, because talking also produces aerosol to a certain extent. So we try to minimize as much as possible. And once the patient goes out, the patient is in a short time, they just pay in a touchless system as far as possible. If they haven't brought that, then we may have to do other medium. And inside, what happens is there are double gloves, as I said. So one glove is removed there at the operatory itself, and then the doctor goes to the duffing room, where very, very slowly, in a sequence again, he kind of removes his PPE. But very slowly. See, when you go there, if you do it very rashly, then you tend to create like kind of a ruffle, and that can create trajectories where if the coronavirus is if it's stuck on your suit or anything like that, that can fly off and things like that. And that's been one of the issues with a lot of our medical friends who have been getting infected during duffing procedures. So we do it very slowly. We keep it in the detergent and 0.1% hypochlorite solution that is there, so that at the source, so we try to kill it as far as possible. Very gently remove everything, and our duffing procedure is over. Gloves out very gently, and outward movement always. And these are soaked in for 1 hour before they are disposed or disinfected again. Then we use fomites cleaning with all the solutions, just 3 times. First, immediately after, we have everything wrapped around, and we just clean that area completely. And then again 2 times after fallow time of 1 hour. Then again we clean it, then only another patient comes, so it doesn't happen straight away. So all those were the sterilization unit. Now this is, again, I've shown you this, what we've done in operatories. So this is how the mouthpiece pulls all the things. Our velocity meter check shows that things are working quite well. We have two units. One is sucked from there, one is from down. It is all at the ground level, because if it's at the ground level, then the airflow is at the ground level. If you put it higher up, then it's going up, so you up your nostrils also possibility. So, and whatever goes out of here is also HEPA filter and UV, so that nobody outside gets infected. So this is what we've done. And I would like to say the art of life is a constant readjustment to our surroundings. That's a very profound thing, because as Charles Darwin said, species that survive is actually who, not the intelligent one or the strong ones, but the ones who can adapt. So if we can adapt to this difficult situation and become better and try to figure out solutions and serve our patients in need, that's the best thing to do in today's time, I feel. Fortunately for me, whatever I was thinking got validated recently also by various studies. We've already implemented it, and before, because there was no study done by anybody like that. So 13th August, this paper came after we'd already installed that, which is great to see actually this thing does work. At the same time, Scots have come with a guideline where if you are doing any aerosol generating procedure, you need to have some air change hours. It's called ACH, means air change hours. That means every hour, how many times the air is changed in the room. So basically all these, whatever we're using sucking devices, they kind of suck the air out of your room. I showed you earlier, my one of the room is 23 ACH, means basically every 2 to 3 minutes the whole air is being sucked out of the room. That means aerosol, other things. So we keep the clean air cleaner from the source itself, and it'll help very much. And another thing I want to, if it's a less than 10, then fallow time, they've kept it 60 minutes. If it's more than 10, it's 20 minutes. Now, fallow time is basically, in our language, we can call it an interval between two patients. And if there is no ventilation, they say, as of now, no aerosol generating procedure should be done. So, in conclusion, I would like to say, our take-home message, I don't call that take-home message, I call them safety first message actually. Our main enemy is our aerosol. I mean, right now, that's what has been even if you look at in a common scenario also, what's transmitting disease is the aerosol. Patient sneezes, patient talks, patient sings, patient shouts, and the aerosol is produced, and that gets into another person's nostril, and that's what is transmitting things. Mostly they're saying that. Fomites, same way it's produced, because you sneeze or whatever and it just falls on the surfaces, another person touches in the nose, and that's how it's. So main thing is management of that aerosol, and we dentists has always been working with the aerosol, so we know this quite well, I guess. Hopefully, I mean, whatever I've done, hopefully it works. Tomorrow, if it's, we don't know the disease is changing so much, it's becoming so much more virulent at times, so we have to be extremely careful of what we're doing. Main thing is, do not let it enter our system, our bodily system, our clinical system, our processes, everything. Let it not enter our system, and let's use physics to evacuate this, rather than I feel a lot of people are using a lot of chemicals and things like that. It is fine. It may be killing coronavirus right now, but it may be killing us also. It slowly, the poison. I always have a saying. I mean, if a pesticide kills like the insects in our vegetables, it does kill us also slowly, right? So, because the same thing we eat, and so much of increase in cancer and stuff like that, it's all to do with whatever kills other being also kills us ultimately. So that's why we have to play with safely, let the main source out, rather than trying to concentrate more on killing. That's what has been the medical science. Now it's about symbiotic relationship with everyone, but at the same time managing each other. That should be our goal. Now, the main thing is understanding the enemy. So we understood what the enemy is about. We're still understanding, and we will be understanding more in the days to come. And adapting to live with it is the new normal. Thank you very much for this opportunity, and I hope if you have any questions, just send it to me just on the comment box, and I'd be more than happy to be at your service. Thank you very much from Kathmandu, Nepal.